Dr. Sri Ganesh has promised to keep the theme of mindful and skillful in life surgery by creating a different platform of how he wants to plan the surgery. So today's life surgery is always going to be a little different, which might help the team of R&Ds, engineers, and also clinicians to think in a different format. Dr. Sri Ganesh, can you hear us? Yes, sir. Perfect.
Good morning, dear friends. I'm Dr. Sri Ganesh from Netradama Super Specialty Eye Hospital. And today we have a 25-year-old male on whom I'm going to demonstrate the Smile Pro. And at the outset, I would like to congratulate Dr. Rohit Shetty, Dr. Pooja Kamar, and the NN team for the very successful and very unique second edition of the Lenticule Congress, which is a conference focused on lenticules, lenticule extractions, and different technologies available today, and also the science and the art of extracting lenticules and correcting refractive errors. So we'll start off without much delay. I was involved in the development of the VISUMAX 800 from 2015, and this was one of the first 5 machines in the world to be installed, and we participated in the global trials of the 800, and I've done more than 3,000 procedures now. And today I will be demonstrating both the refractive workflow and the technique. I will be demonstrating different parameters and different techniques so you can see how it works. So first we'll go on to the patient details. The 25-year-old male. This is the pentacam. You can see the pentacam. Topography is perfectly normal. Corneal thickness is around 550 microns, which is good. That's the right eye. And you can see that's the left eye. And we also do the MS39 because sometimes the pentacam can overdiagnose keratoconus, especially the false positives are quite high. So I always check with the MS39. So the MS39, this is the 6 maps, which also gives epithelial thickness. And epithelial thickness is very important in diagnosis and screening for keratoconus. And this is the left eye. You can see that it's perfectly normal, good corneal, and he's got a cylinder also. You can see the bow tie pattern there. So now we will go to the planning. The refractive workplace is a remote planning station where you can play there. Yeah. So this is the refractive workplace. So here you can use forum. You can go and select the page. Play. Okay. So this is today's patient. So we select the patient, and then this is the refractive workplace. On the EQ, and here you get the IOL master images. And you can see that if it is okay, then you get a green tick. Then you can select the Smile Pro, and then you enter the details, the anatomical parameters, the K readings are entered. I think in the next iteration, it will be automatically taken from the IOL master. And then you put in the treatment center also, which is XY coordinates, which give you the angle kappa, and so you can compensate for the angle kappa. And then the refractive parameters, this is again, both the sphere, cylinder, axis, and then the lenticule parameters are put in, the optical zone, the minimum thickness, and the side cut angle. You also have the transition zone, which is 0.1 here because the patient has cylinder. Similarly, the left eye is planned. You put in the parameters, and after that, you save and close. Okay, stop. Now we will go on to the OR, the screen, the VISUMAX 800. That is the remote planning on the refractive workplace. So anywhere in your clinic or anywhere else, you can do the planning for the patient. And once we go here, you have the patient details. You can import the details, and then you have the same details. You can verify. We always verify the patient and the details again. So this patient has about 1.5 diopters of cylinder, minus 5.3, plus 1.45 at 130 degrees. We are using a small treatment pack. And similarly, we check the left eye, and then we will start the treatment now, save, and then, okay. Are you comfortable? Okay. We'll put the paracaine drops. We avoid putting the anesthetic until we just before starting the procedure. Are you comfortable? Open your eyes and close. Open and close. Just look straight at the ceiling, please. Okay. I tape the eyelashes and I put in the speculum. Don't squeeze, just relax. Keep looking straight ahead. Relax completely. That's good. Close the left eye. Always make it a point to close the left eye, because the patient is opening the left eye, then the left eye becomes dry and you may have dry black spots. Okay. Now we are going to lower the laser arm. The robotic arm comes down. Okay. And then here we again verify the parameters. That's the right eye and the left eye. And you see this sign here. This shows that the cyclotorsion, the markerless system, the cyclotorsion, which is the ocualign, is planned here. Okay. So we select the right eye. And here for the right eye, I'm going to show you a different kind of parameter, which is very low energy. It is less than 100 nanojoules for the right eye, and we are having a very close spot spacing and low energy. So we confirm, drop sucking. Always see that the cornea does not get dry. So once you put the speculum, see, wet the cornea. Put in the small cone. Put in a drop of paracaine. And now I will show you the central line picture. So you move the joystick. Look at the green flashing light, please. That's good. So you center onto the pupil, lower the gantry, and you put on the infrared so you can see the lollipop here. So you can see the green flashing light. Okay, just keep looking at the green flash. So you see the yellow spot is the visual center. The plus blue mark is the pupillary center. So as you go close, you can see you get the yellow circle, which is within 300 microns. 100 is within 100 microns. So we're within 100 microns here. And now you have the cyclotorsion, which shows a 2-degree cyclotorsion. And you can actually compare the image from the IOL master, verify that. And now we can ready to start the treatment. I put off the green flashing light. The green light will disappear. Don't move, please. Hold very still. Start the laser. That's good. See, this is very low energy, sub 100 nanojoules. You can see the beautiful pattern there. There is no opaque bubble layer. So irrespective of the parameters, you should get a very uniform bubble. And that is the access incision. So you have the refractive cut, then you have the cap cut, the side cut, the cap cut, and the access incision. After this is done, then the laser arm moves up. The laser arm moves up, and the microscope arm automatically moves down. So this is the robotic arms. So the technique I'm going to demonstrate is the no dissection technique, what I call lenticuloschisis. I've been doing this from 10 years. I published it in the JRS in 2017. So this is the forceps from Epsilon, the Ganesh fixation forceps. It's a double fixation forceps, so it avoids any torque when you're doing the dissection. So go at the limbus, hold the episcleral tissue there. And you can see that, just look at what is known as the gas bubble escape sign. As soon as I enter, I'm not using a dissector, I'm just using the forceps. Once you enter, you see the pattern will change. Okay, then go on either side. grasp the lenticule, push down, okay? And then you can just, with a peeling motion, you can just dissect. Sometimes if the corneal biomechanics little stiff, then you go anti-clockwise and then you complete. Okay? And then you can just remove the lenticule. So you can see that you get a very smooth, easy dissection. And the advantage of the VISUMAX is that you have a very low suction. You don't have any subconjunctival hemorrhage. This is a cosmetic procedure, so you want the eye to be clear. And because of the shape of the PI, there is no pressure on the eye. You're not applanating the cornea, so you're not distorting the cornea. It's a concave applanation. So that's the right eye which is done. So we'll go on to the left eye, where I'll show you how you can use, again, different parameters. Okay, we'll program. Okay, open your eyes, please. Look up. I just tape the eyelashes and put in a speculum. Open your eyes. The right eye has gone on well. Same procedure for the left eye. Okay. So the laser arm moves in. We verify the parameters, the refractive error, and then you can see here I'm using a much larger spot spacing. I'm using a differential spot spacing. We published this also, where we use more energy for the deeper plane, 4.5 and 4.3. We published this in the GRS, so you get better visual recovery when you use differential spot spacing for the superficial and deep plane.
Sir, a question. Why did you use it based on the thickness, biomechanics, or any other parameter?
Yeah. You can use it in all cases. Sometimes, again, it comes out very easily because the corneas are a little softer. Sometimes in older patients, or if the biomechanics are stronger, then you may have to, like I did in this case, you'll have to grasp it twice.
So
and then do a clockwise and anti-clockwise kind of a movement to actually remove the lenticule with lenticuloschisis.
So it's also important point that you mentioned when you're dissecting with the lenticule rexis, that if one eye you feel that there is a little more tighter dissection, so you can actually change it in your other eye. Is that something which you can? Is that a take?
Yeah, you can do that. See, here I'm going to show the regular dissection technique.
Okay.
The green light. So I put on the infrared, and you can see the central line now. So it's fairly well centered. I go towards the visual axis and put on the suction. So it's within 100 microns of the visual axis. And then we check, there's a 1 degree cyclotorsion here. Compare the images. Okay, and it's ready to start treatment. So we put off the green flashing light. And you can see here it's like 8 seconds treatment. You can see there's one small dry spot there. That's because we were speaking, and then
yes.
Even 10 seconds makes a difference. So it's very important to keep the cornea moist and to do your surgery quickly and not to waste time when you're applanating.
I think that's an excellent teaching pearl here, because we have in this group we have seen that there are more than 44% of them here are planning to adopt to lenticule surgery or done a few cases in the last few months. So having a moist cornea, not too wet also, has a huge role. And I think this is a very important point.
Yeah, you can see that the lenticule creation was just 8 seconds. And here I'm going to show you the regular dissection technique using a dissector. This is the Reinstein dissector. This is a 2 millimeter incision. Open it, go in the track between the cap cut and the lenticule cut, lift up, and then this is the superficial plane. You can see it's quite stiff. In this patient, the corneal biomechanics, the cornea is quite different. I think it's stronger, see? So that is a deeper plane, and you have the stop sign. You can see the edge of the lenticule here, right?
This is something very, very important for all the R&D from all the companies. Please incorporate some form of biomechanical assessment into your lenticular
So this
planning.
is dissection of the superficial plane. You dissect it completely, and then that's the dissection of the deeper plane. There is some amount of resistance here. That's again because of the corneal biomechanics, the same energy with different eye. Actually, I did 2 more patients, same energy. It was very easy. But here you can see that there's a little bit of resistance. You leave a little bit of tissue bridge on the right side and go and dissect the left side and then release the tissue bridge, go over the lenticule, and you can just pull it out. Okay? So that is the regular dissection.
Excellent.
And that's the end of the procedure. It's
Excellent surgery, sir. I think we learned 2 things, 3 actually. One is you can
it's
go
done.
low.
It's gone on well. Okay?
So
The take-home message is you can use different parameters. Here we used almost overlapping spots in the right eye. The duration was a little longer. The dissection was easier, but you see that the bubble pattern was uniform. And it was a very low energy, like 100 nanomicrons. I mean, so 100 nanojoules energy in the right eye. Left eye was higher. It was about 150, nearly 130 nanojoules. And spot spacing, again, we used a differential spot spacing, but again, you saw that the bubble layer was good. There was a small black spot because of dryness, because we waited, we were discussing some things. So it's very important to keep the cornea moist and then immediately dock. And dissection technique, again, where you dissect the superficial and deep plane, and then you can remove the lenticule in one go. So there are different techniques, different parameters, but finally, if you see this, the results tomorrow, I think both eyes will be 6/6 or better. Most of our patients are better than 6/6 on day 1. So if you optimize your energy parameters, if you optimize your nomograms, standardize your refraction, then I think 99% of patients you have 20/20 are better on day 1. So this is my experience. I have removed about 20,000 lenticules, and we have done a lot of work on different aspects, techniques, energy optimization, but I think each one will have their own journey, the learning curve, and as you do more cases, you will learn from your cases how to adjust the energy, how to optimize the energy, and give better results from for your patients. So thank you very much.
Sir,
and if there are any questions, I'll be happy to take them.
Sir, just don't log out. There is 2 models we have created revolving the IOP and the shorter time duration. And this is something very interesting. I know I discussed with you that if you're there, it might help to take this. This is not only for ZEISS. I think every company should try to bring it, the suction faster and quicker, because it's not just the speed. There are lot of biological changes which happens when you create that amount of an IOP in your eye, and that has a huge role in how your wound healing and other things happens at a very, very molecular level, but that's a level which we all have to be aware of. So don't log out, sir. Just keep him.
Okay.
And here, just, no, not this. Okay, the piezo. So this is a very, very important work, and this has a huge role. And I request all the companies to take note of it who are having a little longer duration. So this experiment was done by Dr. Pooja with Deepthi and Panna and Abba here. What they did was we took human globe eyes which were not suitable for transplantation, and she did a surgery using different time durations where you are looking at, if you can go to the next slide, connect the lab also so that we know what they do.
Yeah.
No, go. So this was, we did the surgery, and once the surgery means the model, the surgery was 8 minutes, which showed what Sir had just represented now. And also we used 16 to 18 seconds. These eyes were transported to the lab, and we did studies both from, and this is a live image from the lab where these studies were done. And then we did, this is Dr. Nimisha, who did a PhD with us, and she's a wound signaling expert. She does the work is about how the wound respond to a particular stress. And what we did was we started looking at the stress both in the cornea as well as the stress on the aqueous. And this kind of work is very few literature apart from, not from the lenticule part, but there are a lot of experiments done from the glaucoma and other things. So what was done is, if you go back to, you can put this on the other side. Okay, if you can go back to this particular slide, there is, next slide. There is a shot, which is what Dr. Sir just showed, and long, what is the traditional way of it. So our entire response of a body depends on, like I'm standing here and I'm not feeling the cold, I'm not feeling heat, I'm feeling pleasant, and I'm not feeling excessively unhappy for anything. The whole body's response is driven by your mechanosensitive receptors. For example, if I touch something here, some people have hyper responses, some people have low responses. To me, the most important factors which makes a patient happy or unhappy after cataract or any kind of surgery is how your mechanoreceptors behave. And these mechanoreceptors, one of the mechanoreceptors is the piezo, and if you can tell the full form for people who are interested, the piezo receptors are responsible for nociception, and it is a pro-fibrosis. Fibrosis does not just mean a scar. Fibrosis is excessive change in wound healing. That means the piezo, we did some work on piezo. He's also guiding some PhD students on it. And you can see there the kind of work which happens to find out these channels. So interestingly, when you have a quicker response in your eye, which is shorter IOP and a faster surgery, your piezo responses are absolutely low, which means that your responses are not creating a very, very microscopic fibrotic change, which could have an impact on your quality of vision, whether it's day one or Sir said that, I would probably get my 80-90% plus or 99% of them on a 20/20 vision. So the importance of intraocular pressure and the response has been clearly demonstrated by it. I don't have a 800. I had to use the shorter procedures. And the question he asked me yesterday is, it is very good. This is for every company, including Jonas, who is looking at new machines. Can we test the piezo work on your tears or conjunctival impression cytology? You can actually do it. That means if you use different type of duration of energy. Why is it important is for all the refractive surgeons here, one which you don't see does not mean it does not exist. We don't use an electron microscopy to see your cornea. But if you do an electron microscopy of a lenticule with different IOPs at different time duration, your electron microscopies will show different type of response on the corneal surface. And one of the major factors which is existing in the entire human body, which has been studied extensively, is the role of the profibrotic factors and the piezo. Now, we also did the same thing. We took the aqueous of these patients, and this is from the cornea, and you can see that the TPRV and all those factors are necessary for the feeling of good. That means when you have somebody who complains to you of constant pain or irritation, that means that you have induced a lot of these channels. Interestingly, many of these channels which was discovered in the human body, a lot of people have won Nobel Prizes on them. This is one of the most well-researched field in medicine to have got the big number of awards, because the whole body's response depends on, because the feeling of good, when I say feel good, and the people who who are not happy with contact lenses, or who come to you constantly complaining that I have some pain, watering, cataract, this is what happens. We modulated these channels because Swami here is a big pioneer in working on these channels. We worked on this when I said we use cold contact lenses,
Cold BCL.
cold BCL for refractive post-surgery, and we published this work, it increases the TPRV M8.
Yes.
The TPRV M8 blocks the effect of TPRV1, so your cold dampens the response. So what is very interesting here is, which is very, very important point for everybody, including the companies, to understand, you are actually dampening those responses. And when you dampen, CGRP, what does the CGRP do?
CGRP is one of the key factors which is involved in migraine pain pathway. So you can see the CGRP induction has gone up during long docking. That means you're going to experience some amount of discomfort.
The question is, it's an acute response. So it's not acute response. You create these channels, you create a lot of changes in channels. These patients can go on with multiple different things for a long time. So what is important is, when you have a very short and a shorter IOPs, you are bringing in a tremendous amount of change into a healing, the way your growth factors work, and this has a huger impact in the way your nociception is. That means from people who are using 800, there are very nice ways of looking at nociception. It's a very good study to do. Because you may not find too much of difference between one IOP to the other, but a nociception is probably the way to go. And when we looked at the aqueous, we had to take the aqueous of this patient. If we can come back, Swami, here.
Yeah.
The aqueous showed a huge difference of factors. There was decorin also, no?
Yes, decorin was in the cornea as well. So
Yeah, the decorin, in fact, the Arka here, who is here, I think he is one of the world authorities on decorin, because he has a big interest in working on creating a gene therapy which would change the decorin. This is your scarring material. I use a beautiful platform of IVIS. I have a scar. I can't blame the IVIS. It's patient's decorin which is at fault. The alpha SMAs, which causes scarring after your cross-linking. So after you finish this meeting, you have to take home one point is, the fault is not your skill or machine. The fault lies in your biology, in your genes. And these factors are the ones which will make you have more edema, you have more delayed wound recovery. So it is just not the laser spots and energy, it's how your decorin is. Everything is actually different. So this is from the cornea, and if I change it to the aqueous, you have again, these are from aqueous. That means your intraocular pressure have a different type of an aqueous process. The leukemia inhibitory factor and IL-6 is a classic cytokine which also has its role in corneal stromal edema.
Yeah.
Right? Because it's a T-cell mediated response. When you have a stromal edema, see, whatever I'm saying is not what you see on slit lamp. You can't see it. But the stromal edema is driven by these things. And IL-4, which is actually a pro-19, that's anti-nociceptive. It's like giving steroids. The body secretes its own steroids against anti-nociceptive. This is increased. So the issue is, it was a human, it's not a real eye, and it's very difficult to create these kind of experiments, where you have to go into the eye and take an aqueous. It's not ethically possible. But what can come close to us is doing it on a globe. So what it means here is it has a huge role. For all the companies here, please try to bring the duration closer, shorter, because biologically you have changing a lot. And whoever can go back, there are the companies who are coming out with new machine. Longer duration has huge impact in the way your body responds. If the intraocular pressure can change your two cytokines, which are the most important cytokines of healing, that means that it is going to change multiple as. I did not have funding for this. This was not funded by anybody. So I could only use what I can do, and now I have 800. Because the whole idea of this meeting is to also inform the companies of every companies that when you go back to your R&D, tell them that if something is doing well, that is doing well not just from the optical point of view, it is doing well from the entire biological spectrum. So when Sir says that his quality of vision is better and that is quicker, it means that there is very less edema because you are not changing the aqueous there. And this is a contralateral eye. That means the same eyeball of a patient, one eyeball went shorter, the other eyeball went longer duration. That means I don't have two different patients. Then these patients were not, did not have any cataract surgery done. Not patients, sorry. The people who helped us to do this experiment, which I was grateful for, but it changes the aqueous. Because higher your pressure changes the complete dynamics of aqueous. So this is what I want to say. Anything you want to add, Swami, on this?
So
very nice experiment, Rohit. And I think this shows that whenever you have a prolonged injury or stress, then the response, the inflammatory response is much higher. And there are various factors. One is also the pre-op sedation. So if you have a patient who is very anxious, who is apprehensive, then they actually experience more pain, and probably the inflammation also is more. So it's very important to have your patients sedated. You can see that the patient was very cooperative, and then if they have experienced pain is again one of the factors for inflammation. So the patient is experienced discomfort and pain, then the inflammatory factors also increase. And if your suction is very high and you're pressing on the cornea, if you're applanating the cornea, raising the IOP for a prolonged period of time, then definitely you would expect more inflammation and again delayed healing. So it's very important that you have a good culmination of the technology which actually provides minimum suction, minimum IOP raise, and also develop your skills so that your surgical time also reduces. So it's both time under suction and your surgical time, which is important for the visual recovery and patient satisfaction. And this is something that I think all surgeons should keep in mind, because the body, there is a homeostasis which is there. As long as it's maintained and the fluctuation is not much, then the chemical mediators which cause the inflammation do not go into overdrive. But once you have this fluctuation too much of fluctuation in homeostasis for whatever reason, it could even be mental stress and anxiety of the patient or more surgical trauma, then I think you have much more response, inflammatory response, and also this messes up the healing process. It's a very nice experiment. Congratulations.
I think this experiment explains a lot of how the outcomes may differ. And also, to sum up again, I'm repeating this the third or fourth time, I think companies should look at which is quicker and faster with less IOP, because it changes the complete dynamics of your healing response. Thank you.
Thank you. Thank you very much.
I have a question.
Yeah.
One question.
Please go ahead.
Yes.
Really sorry. Dr. Ganesh, amazing surgery. Just a question on the low energy asymmetric pattern. Since you also have the VISUMAX 500, have you also tried it on the 500? Does it work equally well?
Yes. In fact, the last Lenticule Congress, I demonstrated the same technique on the 500. So I've been doing it on our first publication in 2017 was on the 500. We didn't have the 800 then. So it's just optimizing the energy, and then if you are able to kind of optimize the energy, so you have a very nice bubble pattern. We also described gas bubble escape sign. I was not able to demonstrate it very well here, but if you look at the publication, the video in the publication, you can see that the interface clears as soon as you open the incision, and then you know that you have got a perfect, this is one of the indications that you can do the lenticuloschisis very easily if you have the gas bubble escape sign.
Thank you, sir, and we'll see you in the afternoon. Thanks for a wonderful surgery.
Thank you. Thank you.